spine of the scapula and then the inferior angle. And I want to be right on that. And then I'm going to help with upward rotation and elevation as he lifts up over his head. So come on back down. So once again, I want you to lift your arm up over your head as best you can. And I'm trying to help it. And if he says, if the patient reports that it doesn't hurt as much now, or the person starts to get higher up than they could before, that would be a positive scapular assistance test. Okay? So literally, just assist the scapula up. The scapular retraction test is an interesting one. Again, this is the one I felt like is one that probably not ideal for assessing overhead, but if they're having pain or dysfunction, typically we've got to talk about it, and we talk about it in day 2 for sure, the painful arc. The painful arc, and I guess we can talk about it now with selective tissue tension testing, is when the person notices between usually a 30 to 60 degrees to up to about 120 degrees, that range tends to be painful for them. And then usually when it gets to the top, maybe the pain dissipates. So there's like this arc of motion that just becomes more painful. Maybe for identifying those lower levels in that painful arc. So what you do is you're just going to place, I got to retract the scapula, but I don't want to push him over, so I need to create like some kind of a counter force against him. So when I provide this scapula, now I can just ask you to start reaching again with his arm and start to see, how that changes the amount of motion he's having or how much pain he has with it. So you're literally just trying to provide some retraction for the scapula, and then because it's a scapular retraction test, and then you just have them actively move their arm.
Are you using the spine again?
Yeah, just as a lever, just to kind of hold on to. Because if I don't have that, then I'm just pushing them over, right? So I'm just trying to create a counter force. The flip sign is just your arm at the side, maybe slightly abducted is what the test says. And I'm just going to have you resist external rotation for me, hold. And I'm watching the medial border of the scapula to see if it wings outward at all or not, if it becomes more prominent. So if it does, that's a sign that you may be dealing with scapular dysfunction. Scapular repositioning tests provide scapular external rotation and posterior tilt. And so the way I always did that was I placed my hand on top of the spine of the scapula, and I would just apply that posterior tilting. And so by external rotation, we're talking about this motion here. So when I pull back, I almost put a little bit extra pressure on my hypothenar eminence just to get that little bit of external rotation. But so the idea is, this is a good one for individuals with maybe impingement syndrome. If their scapula is anteriorly tilted quite a bit, what does that do to the subacromial space? It decreases it. So if he's getting signs and symptoms with overhead elevation like pain and discomfort, and I think maybe that part of that is impingement syndrome, by providing that posterior tilting, as he goes up overhead, I should see a decrease in that amount of pain. Because remember, as the force couple with the upper traps, okay, it elevates, it upwardly rotates, but in particular, serratus anterior, because of its, by virtue of its attachment system, is trying to posteriorly tilt the scapula as you go up overhead. If the serratus anterior is not functioning well, or they just have postural anterior tilting, then they lose that subacromial space. But I'm just going to observe his scapulohumeral kinematics without the weight, flexion, abduction, it could be scaption plane, and then with a weight. I'm just going to keep talking a long time so he has to stand there with his shirt off. Absolutely. What the test is described is the person's going to flex their shoulder to 90 degrees, and then we're going to internally rotate the arm, maintaining that position, assessing for their symptom response. The person needs to be in the flex position, not in the scaption plane. Okay? But if actively it doesn't hurt them, then it's not bad to come in and give it a little extra overpressure just to see. It's tight. This is generally very sensitive. You want to make sure the pain is with that concordant sign. That's the most important thing. If the person says, yeah, that hurts, then your next follow-up question should be, is that producing the same pain that you're having throughout the day? If the answer is yes, then you really have a true positive Hawkins-Kennedy test. But this is just simply taking the arm and passively flexing it all the way. You might even leave it there a few extra seconds just to make sure. And again, positive is that reproduction of the patient's concordant sign. Again, both of those tests are just trying to, let's just jam the humerus up against the acromion, crush the subacromial space, and see how well you handle compressive loading through that area. Okay? And anatomically, the main players in that space is the subacromial bursa, the supraspinatus tendon. They're the primary guys that are in there. What we're going to do is we're going to have them put their arm up in the scaption plane about 90 degrees, thumb up position, so forearm neutral. Okay? And you're just going to say, hold on, let me push you down. Did that hurt at all? Yeah, it was 4 out of 10. Okay, fine, 4 out of 10. Let's turn your hand all the way down and now resist. Don't let me push you down. Compare this position to the other position. More pain, positive, or more weakness compared to the thumb up position. It's comparing thumb down without repositioning. That, which is generally, if it's truly positive, is more painful, bringing out that concordant sign, versus when I apply that posterior tilt at the shoulder. Hold on, let me push you down here. Empty can with repositioning. If this position is stronger and or less painful than this one, then that's a positive empty can test with repositioning, meaning I give you that subacromial space, all of a sudden your supraspinatus tendon is able to take on more tensile loading. I think is the last one. I'm not going to demonstrate the painful arc, we all know what that is. The person's going to place their arm at 90 degrees, and once again, you're going to resist that downward. Hold on, let me move you down. A positive sign, we're looking for that reproduction of the concordant pain, is suggestive of a bicipital tendinopathy, long head of the bicep. With the empty can test, the forearm's in neutral, so the humerus itself is kind of in mid-position, midway between internal external rotation. With the speeds test, we're fully supinating the forearm, which is going to fully externally rotate the humerus. It's going to put that long head of the biceps muscle right in line with gravity. So the idea is that that's the muscle that's being maximally apprehension. As soon as you see it, the test is over. Okay? If the person tolerates and they're in that 90 position and they have that apprehension or maybe reproduction of the pain, you can apply a posterior glide onto the humerus itself, the humeral head. So just give back that anterior stability of the shoulder. That's the relocation test. Sometimes I think the test might be called the rebound test, is when you let go and then the person like looks at you like, what the heck are you doing? I don't like that, and that apprehension immediately returns. But there's really no reason to have to go to that. I mean, if you got the positive apprehension, the apprehension test, you give them some anterior support and all of a sudden that's better, that's probably fine. So before you would just let go, I would go ahead and internally rotate that arm and even start to bring it back down to their side, so when you ease off, they feel like my shoulder's okay. The posterior apprehension test is when the person's going to be in the scapular plane about 90 degrees. Okay, place arm in the plane of the scapula at 90 degrees. That's this position here. Okay, and then what you're going to do is you're going to combine horizontal adduction and internal rotation through the humerus. So I'm axially loading the humerus, pushing through that, and then internally rotating and coming across the body. Okay. Again, you're looking for that reproduction of pain, but really the apprehension. Okay. What I like to do with this test as well is, if I could manage it, depending on the person's arm, I'd keep my hand back here so I could feel how the humeral head was moving and coming backwards out of that socket. Load the humerus, and then we're going to shift it. We're going to do an anterior load and shift. We're going to do a posterior load and shift. The anterior load and shift for anterior instability, the posterior for posterior instability. What you're really looking for is how much of the humeral head overrides the acromion. Okay, to stabilize the acromion process and the shoulder complex, the scapular and the clavicle. You're going to provide a compressive load onto the humeral head itself, and then you're just going to anteriorly glide it, and then you're going to apply that compressive load and then posteriorly glide it. Again, just assessing for how much does the humeral head move forward, how much does it move backwards. And a person who's stable, that's not going to move that far. Long head of the biceps tendon instability. So if the transverse humeral ligament is torn for any reason, sometimes the long head of the biceps can come out of the intertubercular groove. Dynamic anterior stabilizers of our shoulder. If that tendon's allowed to come out of place, we've now lost that integrity there. So the Yergenson's test, the way you're going to do that is the person's going to be placed in 90 degrees of elbow flexion, internal rotation, and forearm pronation. And what you're going to do is you're going to be palpating the long head of the biceps tendon. And what you're going to ask the person is to resist external rotation. They are going to externally rotate and supinate their forearm. Okay? The external rotation, okay, when they supinate, okay, we can all agree, when they supinate, the biceps is now contracting. So it's going to be fixated because it's contracting. When I externally rotate, when their arm is allowed to externally rotate, then that tendon might pop out of that intertubercular groove. So that's what I'm feeling for, is for that tendon to pop out of the intertubercular groove. I want you to bring your arm out like this, but I want you to flip your hand over at the same time while you do that. Go ahead. And I'm going to resist that while I let her arm kind of externally rotate. So she's supinating her forearm, contracting her biceps, externally rotating her humerus. And I'm feeling for that tendon popping out of the intertubercular groove. There's a resistance to external rotation, but you got to allow that movement to happen. That's for both posterior and anterior instability, depending on which way you do it. So we'll use your left arm now. The way the test is described, you're going to ask the person to forward flex at their hips about 45 degrees and let their arm hang. So go ahead, bend forward about 45 degrees for me. Let your arm hang. There you go, okay? Just relax, this is loose, loosey-goosey. To assess for anterior instability, what you're going to do is you're going to extend the humerus from that position and then apply an anterior force on the shoulder, assessing for signs, symptoms, reproduction of pain. For posterior instability, the person's going to bend in the same position, but now what you're going to do is you're going to bring the arm into flexion, and then you're going to try to posteriorly apply that force. And they need to stand up nice and tall against your reach. They could probably lean over like a treatment table or something. Push, hold, and let me. Okay. Then we're going to play them in full supination and reapply the same force. Make sure they're in that 10 degrees of horizontal adduction the whole time. More pain in the first position, better in the second position. Okay? 90 degrees of flexion, 10 degrees of horizontal adduction, full internal rotation, thumb down. That's my first position, correct? Push down. Ow, click, pop. Okay, what happens if I flip your hand over? Hold on, let me push you down. Better. Okay, positive O'Brien's test. Or I might even circumduct it a little bit. Okay? Or internal, external rotation of the arm. And what you're looking for is any type of clunking, clicking, grinding sound. Okay? That's the clunk test. You're looking for that clunk. You're trying to produce that clunk. Okay?